we are now moving to another theme, which is a decade of nutrition. Where are we? So this is about nutrition and diet and how that has transformed over the years to where we are, and what are the practical applications of how we take nutrition into the management of diabetes. So with us today, I'm going to just introduce two ladies again. The first one is going to be, of course, everyone knows her, Betty Okere. So Betty Okere is a registered clinical dietitian with over 15 years of experience with skills in the following areas. That is public health nutrition, research, health policy development and advocacy. She holds mastery in health wellness education, sports nutrition, and personal training in medical communication with experience in non-communicable diseases. She's also the founder and resident dietitian at Kilimani Diabetes and Endocrine Center and a consultant for various organizations. So welcome, Betty. The next lady I'm going to introduce, just give me a minute. Is by the name Grace Nyawira Ndirangu. She holds a Master of Science and post-diploma, I think, in renal. So she's a licensed and practicing renal nutritionist at Nanyuki Teaching and Referral Hospital, who is passionate about preventing diabetes kidney disease through education and research. She did her Master of Science at Kabarak University. She's a member of Nutrition and Dietetics Academy Training Committee, a faculty member of Nutrition and Dietetics Academy, a member of the Renal Technical Working Group, a peer review member and writer for Intake Open Access. She is passionate about diabetes remission, prevention, trending research on the same. Karibu sana, Nyawira. Situakaribisha na makofi. The stage is yours, Betty.
Good morning. I keep saying I am good at my craft. I am not very good with AI, so Rilwan, you have work to do. So we'll be talking about a decade in nutrition. Okay. There. So we'll be talking about a decade in nutrition. And this came to mind when I saw this and I said, the food that you eat can either be the safest and the most powerful form of medicine, or it can as well be the slowest form of poison. Every time you look at your plate, you see food as social. You see food as what you need to get energy. But sometimes we do not look at it and see it as what can heal us or what can kill us. If we thought about food in that way, then it means we will make better decisions, knowing that it holds your life, whether you'll be alive or you will be gone. So just as a background, we know that diabetes is on the rise. And just about 2 weeks ago, when IDF released the new atlas, we are seeing a 45% increase globally in diabetes. And currently, we're looking at about 589 million people living with diabetes. But here is the problem. In Africa, we are expecting that we'll have up to 142% increase in diabetes. Do we have the resources to take care of that? Maybe not, and if we have, they are not sufficient. So according to KDHS data in 2022, percentage of prevalence of diabetes in urban areas is at 3.4% and 1.9% in the rural areas. However, overall, we are looking at 4%. I am sure if we did another survey right now, those numbers would be different. But what is making us get to this place? The first picture there, physical inactivity. But the sad part is that this physical inactivity is not just in adults who will say that they are working and they don't have time to do any exercises. But it is in children. We have children who are using their fingers to play, and obesity is creeping in even from a very young age. Now, obesity and overweight is a factor that predisposes all of us to diabetes. So we can't really let ourselves start there. The second picture there is of somebody who has overweight. Now, what has happened through the years is we have glorified excess weight, adiposity. And so when you talk about it, you're either told you body shaming, you know, you're not being fair, it's my body, it's my choice, I'm a big size model, and everything around it. And the last part there is that whenever we look at food, again, we are not looking at it as medicine or as poison, but we look at food from a convenience perspective. As early as 9 o'clock, you will see, because of the convenience of having the apps on our phone, you will see riders with burgers and pizzas delivering, and you wonder why you would need to eat pizza at 10 o'clock in the morning. So I'll let my colleague take you through the journey, and then I'll come to conclude what has happened over the 10 years.
Thank you, Betty. We just looked at what has been going on the last 10 years in terms of the increase in food deserts. So let's see where our focus has been the last 10 years. So the uptake of nutrition has majorly looked at malnutrition as undernutrition, not overnutrition. Remember, we define malnutrition as two concepts. We look at undernutrition and we also look at overnutrition. But then the focus has been on undernutrition. If you can see the image right there, most of us, if you've worked in public facilities where undernutrition is very primary, that is the norm. That is where financing actually goes. But there's been barely any financing going to look at overnutrition and obesity. Other areas of interest have been vitamin A and supplementation and deworming. They call it the VASD program. Breastfeeding, which is very good, by the way, nutrition status, and food security. Only in the recent years is when we are looking at food security as a big influence to nutrition security. Nutrition security has also been left out. If we are to look at research, as far as obesity is concerned, Southern Africa has had majority of the nutrition research, up to 36%. But then now is when we are actually seeing an increase in studies as far as obesity is concerned. If we talk about Kenya right here at home, 2020 and 2021 are the years that I've seen, come up with obesity, and you're looking at prevalence and determinants of obesity. Do we have any studies that are looking at interventions as far as obesity and overweight is concerned? In our country, very, very scarce. So again, this nutrition assessment is the background, is the baseline as far as taking care of anyone is concerned. Now, previous presenters have also talked about this, a big focus on BMI. BMI, the whole time, most studies looking at BMI. Now we're moving from that to having to use waist circumference, waist to hip ratio, looking at weight and height ratio to give us the body roundness index. And now a very big focus on bioimpedance assessment, looking at the bioelectric impedance analysis, which gives us a bigger and truer analysis of anyone who comes to get to see us. Assessment as well has seen an increased use of electric questionnaires. Moving backwards, before 2010, you would see a lot of paperwork, and papers on papers, and which would lead to loss of data. Now, by use of electric questionnaires, we get to put more data in storage that can facilitate more research. And that the number of surveys actually using electric questionnaires has significantly gone up the last decade, between 2010 and 2019. Now, this shift definitely reflects technological advancements, of course, data collection, analysis, which now gets to inform policies and decisions, even at the national level. Now, the support for dietary assessment methods, of course, over the last 10 years was small, but the increase is going up gradually. So what are the diets over the years? Now, here we can dwell a little. Most of us have heard of OMAD, 1 meal a day. Are any of us practicing 1 meal a day? Sometimes, yeah, there you go. So 1 meal a day has been a thing. So that leads to food limitation, intentional food limitation, if we put it that way. How many of us have practiced juicing? Juicing has been a thing. You can see where the fats are coming from, yeah? So this has been the trend. Mediterranean diet, of course, has had its day. Dietary approaches to stop hypertension, DASH, at some point was a really big deal. Low-fat diet, especially being pushed for heart failure patients and cardiovascular diseases. Low-carbohydrate diet, of course, has had its day thanks to a study that we'll be looking at in the next few. Ketogenic diet as well. And of course, a lot of controversy around keto diet, bargaining whether we can use it for type 2 diabetes management, weight loss, and very primary for epilepsy. So now, can we look at what has been informing all this? Do you mind if we do that? Good.
Thank you. So, all this has happened, but then we are evolving from having rigid restrictions about carbohydrate intake. Previously, if anybody was diagnosed with diabetes, then you knew you had to shift from your pasta and eat brown ugali. So we have shifted from that in the last 10 years or so. The focus now is more on dietary fiber intake, and the dietary fiber that we're talking about is glycemic index foods that can also give us fiber, so that you do not just have fiber, but you do not have the other concept. And of course, as we look at the glycemic index, we are now also looking at the glycemic load, and not just blindly telling patients you can or you cannot eat. There has to be an information accompanying it. And carbohydrate intelligence. When we started this conference, we talked so much more about carb counting, why you can eat this and that. So it's not about you can't eat your chapati because you're diabetic. And if you eat it, I know how much insulin I may require with it or what changes I need to do. Then fat stratification. Previously, the discussion was you can't eat your fat. If you eat fat, that is bad for you and everything around it. But we realize we also need our fats for absorption of our fat-soluble vitamins so that we do not create a deficiency out of trying to treat a particular condition. And so now we are stratifying fat and saying this is heart friendly, this you need to moderate, and to what percentage. And of course, individualized medical treatment. Where is the research? There is so much that has come up in the last 5 to 7 years, but I concentrated on these two because as a result of development in the global world and the management of diabetes, we have so many drugs, but are they giving us the health outcome that we desire? Not quite. Now, when we look at the direct study, we saw that above 15 kilograms of weight loss, intentional weight loss, led to diabetes remission. All right? And if just by losing weight because you're eating properly and engaging some physical activity, you can reverse a condition like diabetes or reduce the amount of medication that you're taking, are we still saying that nutrition shouldn't be an important part of management? If we are saying that, then we've forgotten that it can be the poison that kills us or the medication that treats us. The other trial was a look-ahead trial, so any intentional over 7% weight reduction resulted into reduced cardiovascular risk in mortality and morbidity. Again, very, very useful. And this is for patients who have type 2 diabetes. And even if you didn't have type 2 diabetes, but then you are able to get this weight loss as a result of nutrition and physical activity, then you can prevent your risk of developing this disease. What is common in all this? That they start this nutrition either with a bit of restriction in their calorie intake, then you get to a phase where now the meals are being returned back and you get to maintenance. What is the practice where we are? You send your patient to a dietitian, they go once, and they have learned everything that I learned in 6 years. It is a bit unfair. So what are the gaps? Socioeconomic, people are not able to afford the services. So I am a person living with diabetes, and I have to see 5 specialists. It becomes expensive. How about we all sit in one room, The patient is there. Europe has done it, and I think we can copy that from them. And the consultation that we give them is a group consultation. How we will divide it is our business as the professionals. Research, whenever we are doing research. Now, when we look at nutrition in the past 10 years, yes, researches are coming up. But who's leading these researches? It is the physician. It is everybody else. Why are the nutritionists being left behind? Maybe in our training, research is not a big component. How about if we say we are in a multidisciplinary team, we hold each other accountable. And for every research that you do, the nutrition concept is there, hold the nutritionist, move with them. We learn together. Collaborations, let us collaborate. We can't work in silos. And at the end of the day, we still say that we are doing what? Multidisciplinary team approach. Alternative therapies. You have always had these patients who will come to you and tell you, I drank chia seeds or okra water every morning, and I think that is why diabetes has gone. Just as an example, I'm not saying it's true. Alternative therapies are there. Are they affecting our management, whether positively or negatively? Yes, they are. It is time to open our eyes, probably do a narrative, a literature review of what exists and see if it is impacting and in what way. And maybe, again, go back to research and see how they all work. So how does the future look like? We are now looking at telehealth. Previously, it would be if you have to see a nutritionist, you would have to come and see me. But if we all learn that you can do bioimpedance wherever you are, maybe you have a nurse who is doing it, and then you know somebody else has a telehealth facility, and they can be seen from wherever part of the world or the country that they are in, we will be doing much better. Individualized nutrition management is now the in thing. We no longer have, at least where I am, papers that we will pick from a certain safe and give to every patient because the diagnosis is diabetes. And this takes time. We need to all embrace it. We are seeing more and more specialization in nutrition. Nyawira is doing renal nutrition as a specialty. I'm doing diabetes. Somebody else is doing some pediatrics and all that. What is the future of nutrigenomics and nutrigenetics in nutrition management? Again, an area that we need to explore because, again, with AI, all this is with us here, and we can definitely do it better. And the role of gut microbiota in, sorry, I skipped it. The role of gut microbiota in insulin resistance and diabetes. And of course, those are some of the references that I used. But even as I finish, we all have to remember that nutrition is a science. It is not our opinion of what you should eat or not eat. There is scientific backing to it. Thank you.